So thank you very much for your invitation, your kind hospitality. You're warm and you're welcome. This is a picture from last night. We had a lovely dinner, and thank you for hosting a very intimate and special evening, one which I will always treasure. What I'd like to share with you today is a journey that I've had in trying to figure out how do we actually make impact and improve outcomes of children who have had traumatic brain injury. So the objectives for this morning's presentation are really to share with you that there's a lot of variation across the country in the care that we provide kids. I'd like to share with you how we came up with the PEGASUS program, how it was developed, and the results of the program which we implemented at Harborview Medical Center at the University of Washington. Many of you already know that traumatic brain injury is a leading cause of death and disability in children over 1 year of age. There are published evidence-based guidelines and recommendations for how we should treat kids admitted with traumatic brain injury. The problem is, however, that there's a lot of variability in guideline adherence. And there are no TBI programs to improve outcomes. There are programs for sepsis, and there are programs for ventilator-associated pneumonia. But despite the magnitude of the public health burden, there are no interdisciplinary, evidence-based, comprehensive, hospital-wide programs. So these guidelines were first published in 2003. A group of people across the country got together and really wanted to make a difference. And based on review of the evidence, and I was not a part of this in 2003, but this was a really landmark document. This document had 18 chapters and made recommendations for clinical care at various levels of evidence. The document was again published in 2012, and as you can see here, there were some changes. So some topics were dropped, some were added, some levels of recommendation were retained, some were improved, and this is okay. The change is good because it really represented the evolution of how we were thinking about caring for kids with TBI, and the 2018 update is going to be published shortly, we think either January or February. So in 2008, we published a paper trying to understand whether the first iteration, the 2003 guidelines, actually made a difference in the care of kids, and we did one study. And the scientific details aren't necessarily as important as what I will show you now, which is the bars in the red circle. So assume that we're trying to measure a treatment that we gave, and we don't want this treatment. The gray bar represents the treatment that we don't want, right, which is the unwanted hyperventilation for those of you who are clinicians in the audience. And the black bar represents the same data after publication, 5 years after publication of the guidelines. It's still pretty high. We know that unwanted hyperventilation in the absence of brain herniation is probably not good for kids. But the practice still continues, and it continues about 40 to 50% of kids experience this in our care. In addition, the minutes to the first PaCO2 sample was really long before the publication of the guidelines. After it did go down, but not really what we want. We don't really want it to take 40 minutes for a first sample. We've done some additional work showing that ICP monitoring, which is monitoring that we do to measure the pressure in the brain, is actually not as common as we think it should happen, despite recommendations that kids with severe TBI should have monitors placed. In fact, it's less frequent in infants and in pediatric-only trauma centers. Now, that may be surprising, and in fact, the reviewers of this journal, of the paper when we sent it in for publication, said, well, this can't be right, the data can't be correct. Well, it is, and some of the thinking may be that adult centers, or mixed adult and pediatric trauma centers, tend to be a little bit more aggressive in the care of people because our first tenet in pediatrics is do no harm, do as less as you can. ICP monitoring is in general a little bit more common in adult centers, and so this may explain some of our findings. But nonetheless, a lot of variation and not being done. Now, This may or may not, this variation in care may or may not be related to the variation that we actually see in outcomes. So this is a map of the United States. This is a project that we did using the National Trauma Data Bank, and blue is you guys. Blue is the Northeast, and 1 is good. That's the reference. And if you can see, so what does this tell you? I shouldn't pick on Blake, right? Because but I was told I could, but I won't. But 1 is good, and the best outcomes are actually seen in the northeastern United States. The second best is probably the West, and then you can see, and red is not, it's not meant to be a political statement, it was just made that way, but the South doesn't have very good outcomes after severe TBI. So facility characteristics and 30-day in-hospital mortality also varies across the country. We're also sending our kids to rehabilitation centers with variability across the nation. So not all states in the country have the same number of rehab facilities. Discharge criteria of when kids should be sent out from hospitals to rehab facilities varies. And so you can see here that compared to Oregon, the relative risk of discharge to a rehab center, which is what we want, is actually greater in Massachusetts than it is in Oregon or in Florida or even in Washington State, because we don't have many. And that's a problem. So despite publication of evidence-based recommendations, why is it that there's not great uptake? Well, first, some people would argue that there's a lack of strong evidence in those guidelines themselves. They're not based on class 1 evidence, so people don't believe they need to follow them. There's lack of knowledge. There's lack of a champion. And if you look at these lists here, this is not about medicine. This is organizational psychology. This is what it takes to actually make things happen. And these things don't always exist in healthcare systems. So there aren't adequate incentives. And frequently the last part, which is where we're going to talk about the PEGASUS program, is often a lack of an implementation strategy for adoption. We just get told what to do, but we don't really understand how we should achieve those goals. This is a really nice paper for the trainees in the audience, published in 2008. And it talks about really the translation of basic science discovery to potential clinical application. And this is where we really want to get to. We want to get to T3, T4, and T5 stages, which is effectiveness in population health. But most of the NIH dollars are here. And so really translating what we know to be true into practice is really hard. So what is implementation science and how can this help? So the definitions are up here. We're really trying to use strategies to adopt and integrate evidence-based interventions and change practice in healthcare settings. We're trying to study the science of how do we do that. And then we want to disseminate our learning across the country. So the strategies here are to accelerate research to translate it to practice. We want to learn about the best practice that can successfully be applied in real-world settings, and we want to increase access to approaches that are proven to improve health in diverse populations. This speaks to the issue of health equity, which is a major challenge. Those of you in business will understand this very easily. There are 4 elements of the diffusion of innovation. You have to have an innovative product. You have to have communication channels and time and a social ecosystem to actually achieve market share. We don't always have that in our healthcare system. I've been sort of following the work of Peter Pronovost for a long time, and that's because he's really tried to help acute care physicians think about how do implementation characteristics influence the ability of what systems and providers and guidelines bring to the conversation in relation to compliance and patient outcomes. This is a key piece that has been missing in the practice of medicine for a long time. So the project that we undertook is called the PEGASUS project, which is the Pediatric Adherence to Guidelines and Outcomes project. And the conceptual framework was that organizational and provider characteristics affect the ability to adhere to the guidelines and may improve patient outcomes. So we hypothesized that if we actually adhere to the guidelines, patients would do better, that we can, in fact, reduce barriers, and that we can implement an evidence-based program to increase guideline adherence. So Mike Bell was a partner with me when we started this project in 2010. We got some sites across the country. You see the small map with the purple there. And we started to examine our existing data. And what we learned was that guideline adherence matters. In fact, our data showed that for every 1% increase in adherence rate, there was a 6% lower inpatient mortality. And this was adjusted for injury severity and other markers. And in fact, not only did survival improve, but discharge GOS, which is functional outcomes, also seemed to do better. So this gave us a lot of incentive to think about implementing the guidelines and figuring out how to do that. The other question we asked was, is there a dose effect? So the guidelines tell you you're supposed to do 18 things. Well, I don't have 18 hands, and I don't have 18 minds, and I may not be able to think about all of that so quickly. So we tried to see if there was a dose effect. If you do a little bit, you get some effect. And in fact, it looks like compared to doing nothing, if you do something, you actually do very well. So you reduce the risk of mortality significantly by going from adherence that is less than the 20th percentile to something like 20th, 40th percentile. And then you see another step off here. So if you adhere really, really well, the outcomes are the best. So not only is adherence good as a binary, yes, no, but the dose effect of how much you adhere also seems to matter. Now, I said that there were about 18 or 20 things we're supposed to do when we take care of these kids. Well, that's kind of hard to do everything at the same time, and it's not clear which one you're supposed to do first. So when we did some complex modeling, what we learned was that there were some key protective indicators. So if in the pre-hospital period you could prevent or expediently treat hypoxia, low oxygen, within 30 minutes, kids did better. If operating rooms had the availability of hypertonic saline or mannitol, which believe me, not all operating rooms have access to that, which is life-saving, outcomes are better. And if the operating room and ICU environments maintained blood pressure, provided nutrition in a timely way, and ventilated kids appropriately, outcomes also seem to be better. Am I supposed to be done? Okay, no. Okay, I just want to make sure because I don't have a timer in front of me. Okay, great. So, so we learned that maybe if we focused on those 3 or 4 or 5 things, we can actually improve the outcome of kids. So one of the questions our hospital had was, let's say that we implement guidelines. Is it going to cost more money? So we did a cost analysis and, in fact, learned that it costs no more money to implement the guidelines than it does than if you didn't. It's about the same. You can look at the adherence quintiles as you go down here, and then you can look at the ICU, the hospital costs and the ICU costs. Therefore, guideline adherence is, in fact, cost-effective. So that's the what of this conversation. We're supposed to be adhering to guidelines, so that's message 1. The second is, how do we get there? So we partnered with some systems engineers to try to understand what normally happens through an ED, through an operating room, through the ICU, what care is provided in what order, what are the probabilities of certain kinds of x-rays being done within a certain period of time. And this is what's called a value stream map. And what we learned here from our own center is that it was actually taking a little bit longer than we would like to get a head CT scan in our ED. These are data that you won't find in a standard electronic medical record. You won't really be able to tell how soon a consultant actually arrived in the ED from the time that they were called. So we were able to really map this out. And when we compared ourselves to Columbus, Ohio, what we learned that, in fact, 10 to 50% of the ED time was what we call non-value added time. Patients are just waiting. Now, that doesn't mean that they're not being observed, okay? We couldn't really capture that. But what we did discover is that waiting for test results is actually the largest contributor to non-value added time, followed by waiting for physicians and then just undescribed gaps in care. So this was very helpful to us to go back to our laboratory processes and think about, well, when I put the blood sample on this counter, is there actually somebody there to pick it up and run it to the lab, or is there a tubing system? And then it gets to the lab, and then how long does it take for somebody to actually start running the sample and it come back? All of these things matter. So we're talking about the how now, right? The other important how here is actually getting people to do what we think they should do. The first job here is to understand why they don't do it. So here's what we learned. We talked to a lot of people, providers, nurses, physicians, in fact, even patients. And what we learned here was that we could triangulate guideline adherence around 3 domains: issues with clinicians, or issues that clinicians have, issues that the guidelines have, and then the institutional issues. And here's what stood out. The degree of interdepartmental collaboration and cooperation was a problem because we don't communicate effectively. We don't have a shared mental model, and we don't necessarily have shared expectations and decision-making. On the institutional level, institutions were seen to not foster a culture that values review of the guidelines and actually support interdisciplinary decision-making. There wasn't really adequate training and continuing education. And the guidelines themselves are clunky. There's multiple pages in a book somewhere that nobody reads, right? Dr. Holbrook and we were talking about how many people actually go and read books these days. I won't ask everybody in the audience that. But the point is that if you put a lot of pages in a thing, then people may not look at it. So there's a presentation component to this conversation. And yet when we talk to families, and these include limited English proficiency families, they'll tell you that what they really want us to do is to communicate with each other and to communicate with them. They want us to be thorough, to provide compassionate care, to listen, and to involve them in the decision-making. This is really interesting to me. There's a knowledge asymmetry between clinicians and patients and families, and yet all families wanted capacity building. They really wanted us to teach them how to take care of their kids when they transition home. And coordination of care also emerged as a very important component. So amidst this work came a landmark study in Lancet Neurology in 2013. This is work done by Jose Pineda, who actually showed that if you develop a pediatric neurocritical care unit, you actually put ICP monitors more often. So a system is really necessary to improve care. Now, they just looked at ICP monitoring, but it provided us with enough impetus to actually consider developing an interdisciplinary program that begins from the moment that the child hits the emergency department and regardless of where they receive care in the hospital. So there are 3 components to the PEGASUS program. The first is they get a clinical care pathway, which is guideline recommendations, best practices. They get processes of care. So the value-added components that we saw from our value stream mapping, the orders are defined, the order that things should happen in. So should you get your arterial blood gas before you put in a central line, or should you put your central line before you put your arterial line in? Should you put an arterial line in? Those are not described in the guidelines, but we were able to add that. And then perspectives of family and patients on frequency and quality of communication was really important. Our families were complaining that the teams seemed to be giving different messages on prognosis. So we developed structures for how these communication scripts should happen. So that's the what. And then providers needed to facilitate pathway adoption. So we really needed to speak to guideline knowledge. We needed to really involve the bedside nurses in this, document pathway use, share data, and really develop a community that was committed to this issue. And then organizationally, we had to get our leadership, hospital leadership, to endorse, recognize, advertise, and brand the program. We needed to develop adherence to the program and the quality improvement metric, and solicit provider and family satisfaction recurrently, and really develop an annual program report out of it. So those of you who have worked at a county hospital, that's where I work, is a county hospital. Actually, I thought it would be very hard to have an aggressive timeline and push this out. We started this process, assembling the team, in 2014 in January, and by July of 2015, we were implemented across the entire hospital. And this was because people wanted it. And I think systems have to want change for us to be effective. One of the most interesting things we learned is, we said, well, how can we leverage our electronic health record system to facilitate nurses using the recommendations that we developed? And the PICU nurses said, we don't want to. We want paper. And we thought this was kind of interesting. We said, well, that means somebody has to go into you have to write in it, and that means then we have to enter the data from it. And they said, well, if you put it on the computer, Our backs are always to the patient. This is not making me feel good that I have to have my back to the patient even more. I want to stand in front of the patient and write. And I want to give you my thoughts. Electronic health records have fields you fill in. It's hard to write things down. So we said, you know what? This is a pilot project. Let's do it. So there's a page for every day in the child's life in the ICU. And the blue page here is day 4. And there are things that we've written there that the nurses should do and the physicians should do. And people mark things off. And what you'll see here is that the nurses are writing things down. And we have hundreds of packets now of so much rich information where nurses are saying, I've tried to raise the blood pressure and I cannot. I've tried to reach the physician and I cannot. Or the family's struggling with this and here's how I've been able to help. We will never be able to capture this from a standard EHR. So these are really rich data, and it's been successful. So these packets are actually sitting in the nurse manager's office on the floor somewhere. And what happens is when a child comes into the emergency department, there's a packet that's activated. Somebody picks it up. Somebody starts writing in it. And if they go to the operating room, there's an electronic system that I'll talk about in a little bit. But if they go to the ICU, the packet stays. The nurses fill it out. Each packet is 1 week. And if the child is in the ICU for longer, they pick up a second packet. They're filling it out with 93 to 98% fidelity. And when the child leaves the floor, they're actually putting the packets back in the nurse manager's office for pickup. And so I have somebody go pick packets up every 2 weeks. I'm out of it. This is a self-sustaining program. All we do is the data analysis. So the PEGASUS program goals when we implemented this was really our primary goal, because it's an implementation science project, is trying to evaluate the adherence to the key performance indicators, those 3 or 4 or 5 things that I said were crucial, and then look at discharge outcome. So we looked at ventilation, blood pressure, and nutrition. Okay, so there's some lines that are overlapped. I'm sorry about that. But let me just share with you that over the course of the study period, we had 221 kids received the pathway. Some of them received the pathway who shouldn't have, because we was determined that they didn't really have TBI. They had another neurocritical problem, like an AVM or an aneurysm. But in fact, the nurses didn't mind using the pathway and no harm came. And in fact, it was really best practice neurocritical care. So it turned out to be okay. I'm not saying that's our goal, but what I want to share with you is 199 out of 221 kids for whom we intended to use the pathway actually got it. And in fact, our target audience was the kids with severe traumatic brain injury, but some of the nurses started the pathway immediately when the kids with complex mild TBI or moderate TBI deteriorated. This is an innovation, because currently at our place, if you had a moderate or less than severe traumatic brain injury and the child deteriorates, you get a phone call, the person has to respond, and then another order set has to be written. Here, it's not like that. The pathway starts as soon as the child is deteriorating into what the bedside clinicians are considering having severe. So we could actually quantify how many kids in hospital deteriorate. And so we ended up with 193 severes plus 6 of the moderates who deteriorated to have our cohort of 199 kids. We also learned some interesting things. The GCS score, or the measure of TBI severity, in the ED is not the same as in the PICU, is not the same as in the hospital. That means that some kids who are admitted with certain severity of TBI are getting better. Some are getting better and then worse and then better and then worse. Some are admitted worse and they're actually improving and staying well. And so we are now able to capture the trajectory and patterns of actually what we do. And it may be that some people who are on the cusp, we can prevent from deteriorating because they're actually activated and a part of the program. We learned that, in fact, when we try, we can adhere to all 3 of our key performance indicators very successfully. There are only 4 patients in this cohort of 199 in whom we tried and could not achieve our key performance indicator targets. That's terrific. That's only 4 out of 199 kids. And that doesn't mean that we didn't try. It means we may have tried and we couldn't because they were too sick. So if you look at the histograms for key performance indicators and you look at cerebral perfusion pressure, nutrition start, and avoiding of unnecessary ventilation, we have pretty, I would say, favorable fidelity here. We've achieved adherence, 60, 70, 90%. This is much better than we were doing before. In addition, we looked at the kids in whom we did not achieve adherence and looked at what happened to the spread. In other words, we didn't achieve adherence, but did we at least reduce the outliers? Did we change from real bad to maybe less bad? And in fact, we did. If you look at cerebral perfusion pressure, the number of outliers is actually less than before. And so I think we're trying to achieve adherence. We're also trying to reduce unwanted variation. Now, this is a little hard to see for our cerebral perfusion pressure, but this is our ventilation key performance indicator. If you look at the blue, okay, and then you look at the orange, the blue is after program implementation, you'll see that the bounds, the upper and lower values, which are unwanted, actually are streamlined to be more middle of the road. And that's what we want. We want to reduce that variation. Because we did this in a prospective manner, we can confirm or refute, and we've confirmed that the 3 targets that we found from our retrospective study initially are, in fact, very good. We really should be avoiding unwanted hypocarbia. We really should be maintaining cerebral perfusion pressure, and we should be starting nutrition very early. Whether you look at adjusted or unadjusted models, these are key performance indicators, I think, that we can use for the care of our kids. And they seem to work even for discharge disposition. The graph previously referred to survival. So then one of the things we do in science is really replicate studies to make sure that what we find once is what we are able to show again. And with this program, we again are able to show that there is a dose effect. The more you adhere, the better you do. So these are relative risk estimates for survival and discharge GOS. So if you can adhere to 1, that's good. Try to adhere to 2, it's even better. And then 3, it's even better. Now, what was interesting to us is that there's a huge effect on nutrition. And you could argue that you're able to feed kids when they're less sick, but these are highly adjusted models. And we think that the provision of nutrition early on is extremely beneficial. If we talk to the PICU nurses feedback on the program, they're all very happy with it. This is a room of a kid who was admitted with TBI. So when there's a call from the emergency department to the ICU saying that there's a kid with TBI being admitted, the clerk prints out this sign. It goes outside the door and it says PEGASUS patient. So everybody knows that this patient is on a care pathway that should be adhered to. The clerk is involved. He feels good about actually being part of providing good care. And so the feedback that we've received really is that with the PEGASUS pathway, all consults and teams are on the same page. The number of PSNs, I don't know if you call them the same thing, but these are complaints that people fill out about communications and disagreements and also poor care, they have dramatically decreased. So we've incorporated PEGASUS program metrics as part of our Access to Excellence. The hospital looks at it, and the Department of Health reviews it annually. And I think that what we've been able to do with implementation is really achieve high fidelity, achieve favorable outcomes. We've confirmed the role of the importance of ventilation, blood pressure, and nutrition management. We can quantify the deterioration of patients who are admitted with less than severe TBI, but who may actually be able to be saved because they're quickly treated with a program that is efficacious. And we can inform the Brain Trauma Foundation guidelines that, hey, there's a program out there that may actually be able to implement what we're recommending. Now, Mike and I are both on the Brain Trauma Foundation guidelines, so we should be talking to ourselves, I guess, to make those recommendations. And it really offers a new approach to TBI care. The local impact has been that the dean has been very happy. He's sort of put it out in the annual report. It was cited as a highlight of the Accountable Care Network. The Department of Health has lauded it for being a major innovation in trauma care. We will be talking to the Brain Trauma Foundation to incorporate this as a recommendation. So I think we've really transformed care, and there have been some community benefits because families feel more empowered to be part of that conversation. So if you'd like to learn more, the paper that actually speaks to the details of the program was published in the Lancet Child and Adolescent Health around Thanksgiving, and there's a podcast that is also available to sort of give a summary. So we're really excited about this. We're hoping that this will launch the program as something that other centers can adopt as well. And Mike and I have an NIH grant that should be funded if the government doesn't get shut down, hopefully, that we are collaborating on to implement and test the PEGASUS program in Argentina. So that's very exciting for us. So this is why we're all here today. We're here because we love our kids. So I'd just like to leave you with the message that the PEGASUS program leverages implementation science frameworks, improves guideline adherence, and translates evidence to clinical practice. So I'd like to thank the funding sources, the PEGASUS, the development team, the PEGASUS program team at Harborview and Harborview Medical Center for really being a wonderful environment for us to really test this innovation. And thank you for having me. Yes.
Really outstanding work. Congratulations, and thank you very much for sharing it with us. I'm interested in hearing a little bit more about the patient engagement piece. Was there a component of asking families, for example, about their needs, their desires, and how was that incorporated into the implementation package?
Thank you. So the question is to comment on family engagement as part of the program. So families, when they arrived to the ICU, received a packet, much like you folks are giving here, and that includes setting the expectation that their child is receiving is part of this program. And what we have written for them and talked to them about is every day during rounds, families who participate in rounds, who are there, can affirm, is my child on this pathway? So those patients who are missed can be caught. Second, we informed patients as to what we're trying to achieve. We're trying to achieve blood pressure and nutrition and ventilation. So families are encouraged to ask the question, how are we doing on those metrics? So that really empowers family to be part of the team. So I think that's been something that's been successful for us.
Thank you so much for that talk. It was outstanding, actually. You touched upon something that I've kind of grappled with as well about the paper chart. So the nurses loved the fact that they could write in that paper chart. You know, they felt like they could spend time with the patient.
Yes.
And I actually wholeheartedly agree, but I'm sort of developing into a data person. So for sort of the longevity of the packet and also sort of a long-term implementation into the EMR, because everything is getting very electronic these days, what do you foresee sort of the future of this packet?
So the goal, right, always the goal. The goal is to take really good care of kids. End of story. I hope we can do that with EMR, right? What I'm trying to do is work with our IT. We're going to undergo an epic transition in 2020. Okay, happy yes, right? So what I'm trying to do is work with the IT folks to see how much of this packet and what fields we can incorporate into the HR so the nurses can enter similarly. But I am worried that we can't get all of that information in there. So my strategy is try to work with Epic, but I'm going to continue to have the packets available for the nurses to use. Because Epic is there for billing and compliance, okay? Bottom line. We also would like to provide best quality care. And so it may be a layered model where they do their Epic. And, you know, at the end of the day, if the nurses are going to actually be engaged, then I would not feel good about with taking those packets away from them. It's so much a part of the ethos right now. I will tell you that this program has been so successful that we now have a spleen program. And we have the burn service has adopted this model for burn care, which is extremely challenging. And there's a geriatric trauma bundle that has been developed based on this. So this has had huge impact across our healthcare system, and I'm probably going to jump up and down if they try to dismantle it. I will jump up and down. Yes.
So you may not have a direct answer to this, but I am really fascinated with your story of how your nursing teams really joined you and they were essential to your success. You would not have been successful without them. What was the secret sauce there? How did you get their engagement at such a deep level?
Okay, that's a really great question. So innovation often arises from chaos. Not that I'm saying we had a chaotic ICU, but maybe we did. I think there were a couple of key factors. One, we had data to show that we weren't delivering the care we wanted. And I think we cared to deliver. So understanding what motivated our nurses was really key to this, and our bedside nurses cared to be good clinicians. And I think leveraging that and appealing to that with data to show, we could be feeding you 2 days earlier, but we're not because we're not thinking about it, or there are biases that nutrition doesn't matter. And in fact, it does, and here's how. And we told stories. We attended nurse staff meetings. And so we started to have that conversation. It took a period of 3 years because as we were collecting our national variability data and doing our focus groups, the conversations themselves actually increased awareness that this was a challenge. And so I think by the end of it, there was such an organizational will to want something like this that it was so easy. So I think we had a problem. And I think, it's hard to solve. It's hard to implement solutions to a problem you don't have. So I think part of it was we wanted to do better. Can I say one thing as we're doing mics? We also did a lot of recognition of clinicians who participated. I mean, there was a lot of positive reinforcement that went into doing this, and the nurse managers were key to recognizing those folks.
I'm curious, again, thank you for such a great talk, very exciting work. I'm curious as to what might have been your most surprising findings that came from those written logs from the nursing staff.
I think there are a few messages. One, that they really tried to follow the order sets that are there. And sometimes they're not able to achieve the goals, even when they try. And blood pressure was a key example of that. Some kids are just refractory. You cannot do it. So if we're just looking and saying, well, you didn't meet the target, we're doing badly, it's not actually true. The logs will now will allow us to identify the proportion of kids with severe TBI in whom we should reasonably expect to be able to improve CPT. Because when you have very sick kids, particularly with polytrauma, it is very difficult to achieve certain targets. Not that we don't want to, but it's hard to. And we learn a lot about what efforts nurses actually go through to try and get there. So that was very educational for us. The second was the use of interpreter services. We were struggling with getting timely interpreter services to those families. So we made a switch to use the AT&T operators because we didn't have enough staff round the clock and on weekends to have in-person conversations. So that was a system-wide change that was implemented because the nurses told us that they were struggling to communicate with families.
I have a quick question. One of the difficulties with implementation guidelines is maintaining adherence through time. What strategies have you used both to maintain it for relatively infrequent events such as severe TBI, and what other strategies do you use for sort of in-flight course correction, like you have a child where a guideline is not being adhered to for some reason?
So it's very interesting. At our place, it's sort of become the thing to do. In fact, the physicians are writing in the chart, PEGASUS patient. And when we looked at the initial adherence rates, they're actually pretty high. The adoption of the packets is really high in the first 24 hours. I agree with you. I think the sustainability plan, in addition to trying to figure out how to work with our electronic health record, is also repeated messaging around what are the key performance indicators, annual or biannual updates of the packet to include updates from the Brain Trauma Foundation guidelines and other things that we would like to see incorporated. And then it's really a PDCA cycle. It's really a continuous, it has to have a life of its own. And there has to be a champion for that process built into other things like CLABSI and UTIs and other things like that. So at our place, we admit about 90 kids a year with moderate to severe TBI, so it's not that infrequent for us. And I think the nurses, when they are orienting, actually take the program as a little mini course. And then we present at the hospital-wide trauma conference biannually how our kids are doing. And then we're also part of CQIP, so that our TBI outcomes are measured independently. So there's some independent verification that occurs in terms of our outcomes.
Having trained in adult hospital and city hospital, how do you use these guidelines in adult hospital when a traumatic injury with traumatic brain injury child goes in adult hospital? Can they use these guidelines? Are they trained in these guidelines?
So we are a mixed facility, right? We're a level 1 adult and pediatric trauma center. In fact, it works great because people are so conscious of the fact that this is a special population that it hasn't been an issue. Adoption has not been an issue. Was that your question?
What about adult hospitals that don't have a pediatric center?
Yeah, so, right. Yeah, so this is very interesting. So we've recently received some inquiries from Alaska, from Oregon, wanting to understand how to adapt this for their local environments because they're not a level 1 trauma center. So we are in the process of trying to work with them to adapt the program for their context because some things may differ. You know, availability of CT scans may differ. The availability of nurses who understand physiology. And so what we write in those packets may actually change based on the facility. We haven't done that work yet, but we're just starting to. Because you're right, many kids with severe TBI are not taken care of at a level 1 trauma center, especially initially.
Well, on behalf of all of us, I just really want to thank you for an inspiring lecture, not only the science and the tremendous progress you've made, but for this sort of peek inside how you made all of this happen and the journey that your own ICU has been on. That's something we care a lot about here, and I know we're all walking out with a lot to think about. So thank you so much.
Thank you very much.